Good evening, ladies and gentlemen. Welcome to this Gresham lecture, and thank you very much for coming this evening. As you can see, perhaps rather unwisely, I've chosen to talk about economics or some aspect of economics, not just because it's budget day and that I didn't plan that in advance, but also because I'm reminded of the words of Lyndon Johnson when he was interviewed by Kenneth Galbraith when he was talking about economics, and I'll leave you to read what he said, and the conclusion is equally valid, I think. So I hope I don't make it too tedious for you. So why do I want to talk about economic aspects of such a specialized service as surgery for congenital heart disease? And the first reason is obvious, that we have had a financial crisis and a political decision was made to impose austerity, which we'll consider a little bit later in the talk. And the second is a challenge from a friend and colleague who works in Bangalore in India. This is Devi Shetty. He is a cardiac surgeon in Bangalore. And this is the question he put to me. What moral right have you got to charge $50,000, which is roughly what it costs in this country, to do a cardiac operation in a child, when I can do it for less than $3,000? Now, I think that's a very important question, and it keeps me up a little bit at night, partly because I think there is a moral basis for the question, but also the impact of the government's policies over the last few years has been direct in our specialty services, because we're really challenged to deal with increasing demand and increasing demographic changes and getting less money to do it. And with a higher public expectation, we're being asked to do more for less. And so today's talk covers some of those issues and sees whether or not it's possible to think about some of the things that Devi Shetty's done in India that we might be able to do here. Now, I'm sure it's not an easy thing for anybody not in the business to understand, but how does the cost accumulate for a child passing through the system that ends up costing a lot of money, as it does in our business? So I thought I'd trace the pathway of a child with tetralogy of Fallot, which is a condition which we treat here and is treated in Bangalore, and it's a pretty standard mid-range operation. You might remember from our first couple of lectures that the blood coming back to your body, having had the oxygen taken out, coming back to the heart from the body, comes back to the right atrium, passes through the right ventricle and out to the lungs, where it collects oxygen, and comes back to the left atrium with oxygen in it, and so red, and then passes through to the aorta. In tetralogy of Fallot, the way out of the right ventricle is partially obstructed by some extra muscle, and the artery is narrow, and the valve is narrow. So the resistance to the flow of blood coming out of the right ventricle is high, and so blood tends to take the easy route and go through to the left ventricle, making you blue, rather like the hand over here. And to fix the operation, we need to look at the real morphology. And here's a normal heart on the left and a child with tetralogy on the right. Here's that extra muscle, the narrow valve, and the big hole between one ventricle and another, which makes the blood red. Now, to fix it, you have to close this hole and widen this area out. And you sometimes can't do that when a baby is newborn, and so you need to be able to get some blood to the lungs, and we put on a little shunt, a plastic tube between there and there, to tide them over until they're a bit bigger. The journey of a child through the healthcare system has come to be known as a pathway. So I thought it would be instructive to take a little journey with this child with tetralogy of Fallot through our system. And in tetralogy, in this country, it starts before birth. Because when most babies have a fetal scan to see what the baby looks like, and then if a cardiac anomaly is diagnosed, they'll have a cardiac scan or 2 or 3 before being delivered locally if the baby's reasonably well, or at a specialist centre if they're not. After birth, they get a cardiac scan in a specialist centre, and then we discuss what to do about them at a multidisciplinary team meeting. If they're well, they can go home and wait to have the definitive repair at 3 to 6 months. If they're not well and they need the shunt operation, then they'll go into an ICU, have their operation, and then eventually go home some days later to be followed up in the clinic and with more cardiac echoes before coming back to have the definitive repair after another MDT and then going home and being followed up. Now, those two big admissions, if you shunt if you need one, or an operation, are very labour-intensive, extremely labour-intensive. We have highly specialised nurses, highly specialised surgeons, highly specialised anaesthetists, intensive care facilities, expensive beds, lots of equipment, and you don't need to know very much about it to see how the cost can accumulate. After they've gone home, they're seen once more before they reach the adult life and are passed on to the adult system. And at that stage, may or may not need a second operation to fix the valve between the heart and the lungs. So how much does all this cost? It's difficult to allocate costs in the NHS, but this is a product of a study, which I'll show you in a minute, based on 20, 10 or 11 prices. It costs about £200 for a generic fetal scan. This is cost, not cost with profit. This is actual cost. £400 for a cardiac scan. I don't know what a delivery costs because it depends whether it's local or specialised. £400 for another cardiac scan. Getting a lot of doctors in a room to discuss a patient over a period of time is quite expensive. It's about £3,000. £30,000 for the shunt, and then sequentially some more, and another 30,000 or so when you have your big repair. That adds up for an individual child at 2010 prices at around £65,000 over life. Quite a lot of money. And of course, in a cost-contained environment, someone's going to ask you, it's cost a lot of money, but is it worth it? How do we value what we do? What's the worth of doing this? And this is actually the only paper in the literature looking at the lifetime costs of managing a particular child with a particular condition. And in this case, it's tetralogy of Fallot, and it comes from Great Ormond Street from two of my colleagues who we've come to know as Kate Squared. They split up the amount of time, the proportion of costs, as it were, that were for each of these phases. So this is the big repair, this is the valve repair when they're teenagers, and this is the amount of investigation costs. So 75% of the cost is coming from the two big procedures and investigations. Now, to know whether it's worth it, the currency that's used in medicine is a thing called a quality-adjusted life year, a QALY. And that's based on the number of years that would be added to life by the intervention that you do. Each year of perfect health has a value of 1, and if you're dead, it's 0 value. And the quality of life is, if it's reduced, so the value is reduced to some value less than 1. So let's try and give you an example. If you live for half a year in perfect health, you live for 0.5 of a QALY, because you have 0.5 years at 1 perfect quality. If you live for 1 year, but you're bedridden and have a utility of 0.5, you also live for half a QALY, if that makes sense. And you estimate your quality of life by a lot of conventional scores. So this is a way you can compare the cost of treating certain conditions. And this is what the Kate Squared group discovered, that if you don't treat patients with tetralogy of Fallot, you have a QALY gain of about 2 years. And if you do treat them, you get a QALY gain of 35 years or so, and a total cost of care of £65,000, as I showed you, and a cost per QALY of £2,000 to £3,000. So each added year of life costs £2,000 or £3,000. And I think most of us would think that was extremely worthwhile. But note that there are a significant number of outliers who are costing up to £250,000 over their life, and each condition that you see will have a significant group of patients who cost a lot of money to look after. And of course, when you start the treatment, you don't know where they are going to be on that spectrum. And morally, if you did, would you treat them or not? Become questions that, as the resources become less available, people start to have to ask. It's a lot of money, and this is a relatively cheap condition out of the ones that we treat. But how is it all paid for? Well, in the UK, health expenditure largely comes from taxes and things called co-payments. So you, out of your taxes, some money is diverted to healthcare, and co-payments are things like prescription charges and dental treatment, which are not really covered by the NHS. Over the course of the life of the health service, the cost of healthcare as a proportion of GDP has risen from 3.5% up to about 8.5%. The proportion spent as billions has increased more, from 11.4 to 121 billions, a factor of 10 in billions of pounds. And that's about £2,000 a head, healthcare for each of us in this room, which isn't too bad, I don't think. This data comes from a very good study by Capita, by the Civitas, by the way. Now, how that money gets through to us has changed many times during the course of my lifetime and my professional career. When the health service started in 1948, it was a remarkably simple, linear organisation from the Minister of Health right down to the teaching hospitals here, with local authorities dealing with local services and some other general services being dealt with in a different way. But the vertical governance was quite straightforward. It became a little bit more complicated in the 1970s, particularly with the development of a lot more community services and separate family practitioner services. But the real big change came in the 1980s with something called the internal market. And ironically, it was precipitated by a crisis in which a single child couldn't get into the intensive care unit in Birmingham. And one of the cardiac surgeons there, who was particularly vocal, somehow managed to get up the political agenda, and it got right into Downing Street very quickly, where Margaret Thatcher was living at the time. And based on her beliefs that the market any market had a significant advantage in terms of decreasing cost, improving efficiency, delivering quality and innovation, and greater responsiveness to the needs of the people. And as a result, she decided, a group that she set up, decided to create a thing called the purchaser-provider split. Now, we'll come back to whether this is a real market or not in a minute. But by the time the turn of the century came around, it had evolved into something that looked roughly like this, where money was flowing from Parliament to the Department of Health, to the strategic health authorities, or directly to things called primary care trusts. And the primary care trusts functionally held the budget and bought care from provider units called trusts. That's the hospital like Great Ormond Street. And each year, we had to negotiate with the primary care trusts. At that stage, there were 152 of them. Separate contracts for the amount of work that they were willing to pay for. That was on the amount that they were doing as a volume of cases, but also as a price. But it wasn't, and that was done on that sort of flat negotiation plane. But it wasn't really a price, because the system that had been introduced was called payment by results, although it was probably payment by volume or payment by activity. And it's really hard to explain unless you use a worked example. And so I'll use the government's own guidance for payment by results. And this is taken from that guidance. We use two patients. This lady who's having a caesarean section, and this chap who's broken his hip. Now, when you have those patients going into hospital, the period of time that they're spending in hospital has come to be known as a spell of care, spell. And each spell has to be coded for the diagnosis, ICD-10, and coded for the procedure. And there are thousands of these codes. So once those codes are created, the codes are written down and searched through in the medical records by specially employed coding clerks. And those coding clerks then submit those coded data to the NHS, and the NHS put them in a computer box, which we know as a black box, called a grouper. And the grouper then allocates a thing to a health resource group, or HRG, which has its own code. Each one of those has a tariff which is nationally set. Tariff equals price. And it's an average between John O'Groats and Land's End, an average price, which is then modified if you have a long stay, or maybe you're delivering best practice, and then it costs more to treat them in London than it does in Leeds, so there's another little bit of a fiddle that goes on, and you end up getting some money back for the work that you've done. Now, you don't, again, need to be a rocket scientist to understand that the introduction of this system required a hell of a lot of people to manage it. It required you knowing all of the codes, it required them checking, it required them to be passed through, validated, all the data to flow backwards and forwards, people in finance at one side and people in finance at the other side, and then people to manage the negotiations on an annual basis. It was a lot of noise. And people looking at the internal market, as Civitas did just recently, showed that the market itself has had only modest improvements in efficiency and activity over the time that it's done, and it was really difficult to relate any improvements in health performance to the market reforms themselves. What had happened was that power had moved from hospitals through to primary care and from providers to purchasers, which you'd think might be an advantage, but we can discuss that later. The reason they thought it had failed to deliver benefits was because the individual providers had absolutely no control over their prices. If you're making something as a factory, you can control the price and you can adjust your whole way your business works in order to keep that price low and attract more business. Here, we not only can't control the price, but we can't control the volume we do either, because somebody is constraining that because they want to keep their costs down. So there were weak incentives to engage any of us in this process and to break traditional patterns of behavior, and a lack of a stable policy environment, which I'm going to talk about in a little while, contributed to this difficulty. Despite that, despite the fact that the market reforms were difficult to prove that we'd had any a special benefit, in 2014, the Commonwealth Fund compared our performance with the rest of the world, New Zealand, Europe, and the United States. And here on this graph, look at the proportionate amounts that we spend on healthcare worldwide. So here's what the US spends as per capita per year. It's twice what the rest of the world spends. England is a pink line there. So we're one of the lowest expenditures per capita. This is based at 2010 data. And the same thing here. We are the lowest percentage of GDP in Europe. And the average European figure was 8.9%. And America is 17.7%. Are Americans twice as healthy, and do they live twice as long? I'll leave you to work that out. That's what we spend, but what you get from it in the NHS is a number one position in the world in terms of most healthcare performance issues. It's 2010. So if looking at quality of care, effective care, safe care, patient-centered care, 1. We're not very good at not making you wait, but we're third in the world, and we're very bad at healthy lives. And the reason they said in the Commonwealth Fund that that was the reason was because we have some of the worst health inequality in the country. The difference between our rich areas and our poor areas in terms of lifespan and care can be decades and poor quality. And we're doing much better than the Americans, who are appearing very poor on their performance criteria compared with us at twice the cost. What's not to like? This is 2010. So everybody thought it was pretty good, and David Cameron in his Tory party conference speech said, "I make this commitment, there will be no reorganisation of healthcare." And it's difficult to see whether there was any reason for one. We were the best. Andrew Lansley said no more top-down reorganisations of healthcare in 2007, when we were performing extremely well. Within 2 months of their winning the election, they commenced the biggest top-down reorganisation of the health service that's ever been seen in its history. And if you remember the structure of the NHS in 1948, this is what it was, and this is what was sketched out in 2011. Just as simple, I'm sure you'll agree. Now, Banksy has pointed out that most things look better in a circle, so it wasn't difficult for the NHS to find a better diagram than that organogram, and they put this on their website for how it's organised. And I have to tell you that navigating this is extraordinarily difficult. I'll show you why in a minute. When these Lansley reforms came through, Sir David Nicholson was the Chief Executive of the Health Service. And this is what he was quoted as saying about the Lansley reforms. And it certainly felt like that. For those of us working within the system at the time, this was the biggest change we had ever seen. And it seemed to us utterly ridiculous because we were doing so well, making it safer, delivering higher quality for low cost. It looked like the right thing to do. We were on the right track, and we didn't really get what it was. We're beginning to understand what he was talking about because he was recognizing the shift in demand for services into social care because of the aging population. And we know a lot more about that than we did then. How the money flowed in 2013 is shown here. It went from Parliament, Department of Health, through to NHS England, 27 area teams. Some of it comes to people like me in specialty services, and some of it went to clinical commissioning groups where GPs held the budget and started buying care. Still, complex negotiations to work out what you're allowed to do. For us, our negotiations in theory have got simpler, but for everybody else, they've got harder. And the other new thing that's crept in is not just the flow of money, but who can influence where that money goes. In the background to all of this is a load of other bodies who can give a view or have a view and nudge things in different directions. And these range from Public Health England, local authorities and their various committees, NICE and so on. And there's a whole other batch of these things in another plane that go backwards from this slide. People have tried to draw this out in a number of ways. This is a King's Fund diagram, self-explanatory. My favourite was this, which was in the Daily Mirror, which is just about London. This is how you're supposed to navigate the system of London healthcare in 2014-15. You could look at it in a circle if you're Banksy. I don't think it makes it any easier to understand how to work your way around. What do you influence? Who do you influence? Who do you consult? This is not a system which makes it easy for a board decision to reach the shop floor or vice versa. Then along comes the financial crisis, roughly 2008, 9, 10. And I don't know anything about money, so I had to look at a book, and if you want to read a really great book about explaining why the financial crisis occurred, this is the one you should read, Whoops, by John Lanchester. He quotes very early in that book from a mathematician called John Allen Paulos, who carried out a thought experiment because most of us, in trying to understand billions, have a major problem with big numbers. What are big numbers? So his thought experiment is this. Without doing the calculation, how long does 1 million seconds last? Well, it's not University Challenge, so I'll give you the answer. 11.6 days. How long does 1 billion seconds last? 31.7 years. Right? How long does this is the easy one. How long does 1 trillion seconds last? 31,700 years. Now, I somehow find that easier to grasp than £1 billion. But nothing sets it in context like this brilliant animation from David McCandless, which was done in 2010, which relates the cost of stuff to other stuff. And I'll let it talk for itself. So that's the Iraq war that came down, that big black one on the brown one on the right. Lakshmi Mittal's not doing badly. Even then, people were ripping the tax laws off. Tesco didn't do badly then. Look how little it would have cost to save the rainforest. Wait for the NHS expenditure. It's not much out of our annual budget. But it's nothing compared with the total global cost of bailing out the banks and dealing with the deficit. How can you express that scale and look what it would cost to pay off Africa's debt? When you see things in comparative terms, these numbers mean something different. I didn't understand a couple of terms. I had to look them up. The national debt is what we owe, and the deficit is the gap between what comes in and what goes out, the income and expenditure. And there's been a lot of... they get interchanged quite often, and I find them hard to grasp. This graph covers the deficit that occurred as our government, in common with many others, moved some money to pay to bail out the banks, basically, and to sort out the financial crisis. It was 11.2% of GDP at the turn of the governments. The national debt, which is what we were owing at that time, really rose dramatically after the financial crisis because we'd had to borrow so much to get ourselves into that position. Today's budget, very hot off the press, is that is predicted to go down to 72% of GDP in 1920. But that's still a significant debt. Historically, however, our debt is not enormous. So this is 1900 and this is 2012. Each war has created a UK national debt of some scale. And the debt that we're panicking about at the moment is very modest by historic standards in the UK. Interesting policy decisions that have occurred. To deal with this acute change in public finances, one of the policies that you can adopt is austerity. And austerity is a mechanism of correcting the course of the economy by raising taxes or reducing spending. Historically, austerity has always been suspect because people have felt that it will always produce a recession, it will always increase unemployment, and it will always reduce expenditure by the public. Osborne didn't believe that, and he felt that he should do a couple of things. And he worked on a roughly 80-20 rule, which worked out a bit differently. He would put taxes up by 15% and reduce public spending by 85% of the proportion that he wanted to make the corrections in austerity. These are significant proposals. And as he said today, he wanted to fix the roof while the sun was shining. Because in 2020, the baby boomers reached the peak of moving into the pensionable age, and we have a huge social security bill which we're somehow going to have to pay for. The consequences of taking an austerity approach where you take away public spending are that you hope that the private sector will pick up the pieces and that the jobs that you force to lose in the public sector, which have been massive losses of public sector jobs, 20-30% cuts in government department budgets, will be picked up by the private sector. We have reduced our deficit, and these are today's figures that he announced in the budget, where he's hoping to have the borrowing down to zero in 18-19 and then corrected after that to become in surplus. And our debt, as you saw, will reduce, and the hope is that we reduce our interest payments on that debt to somewhere in the 30 billion a year. These are not small sums. But the only way he's been able to do this, as I understand it correctly today, is to take the windfall of selling banks' shares back to private sector and the banking taxes to bring this down. He has not reversed the decision to remove money from the public sector at all. So even though the budget has brought a balance between income and expenditure closer together today, the real problem for the public sector is that we have only just begun the cuts. Only just begun the cuts. They're going to get much worse during the next few years. Much worse. Much, much worse for the health service particularly. The idea of a shift from the public sector to the private sector can make sense in a number of areas. But for the NHS, there fundamentally is no private sector to pick up the pieces at the moment. There isn't a structure which would allow this work to go from one place to another. In other words, we've got the same demand, but no money. Now, there are other views on austerity available, and I'm not here to make any kind of political point. I just would recommend the central book to you, Austerity Bites, which moved me enormously because it looks at the social consequences of austerity, and it's a very good read. So what about the NHS? This, when Nicholson introduced those reforms and when the austerity package was first put in place, it was calculated that we had to make £20 billion of savings because the income coming to the NHS has stayed exactly the same. We were protected compared with the rest of the public sector, which had had cuts. We were held the same, but our demand was going up. When Richard Douglas looked at this, he calculated that actually we were going to have to save 50 billion before 2020, which is a lot of money. Putting it another way, we had had a situation here where we'd had real growth over the decade up until this government, and then the government decided to protect the NHS, as they called it, and that meant giving us no real terms growth in income for the first time in the NHS's history. But the demand was continuing to rise, and so there was a gap between the cash we had and the amount that we needed to deliver the services. And so this was our cost and demand pressures and our productivity improvements that were needed. Now, this is a graph about GOS. I made it nearly 3 years ago. And at that time, the government had decided that they would give us less money. And a hospital in this system, we were going to get 1.8% less on those tariff prices, the unit price for what we did, 1.8% less per year for a decade. So we knew we were getting less per unit of work done. But what's hidden away in that is that there was a built-in wage inflation. Everybody got an increment on a regular basis. Even though there's been a wage freeze, we haven't had any pay rises for all of this time. And the stuff we buy, which very much of which comes from abroad, goes up by nearly 3%. So the gap between what we have and what we need is that much. And those are the savings that year on year we have to make in order to break even. Because the financial situation has suddenly got so much worse, we now have to make very much more savings in year from this year onwards. The gap is rising because there simply isn't, the cuts are now just beginning to appear, and the tariff is being reduced by about 3.8%. What other businesses are working like this apart from the suppliers for supermarkets who are often squeezed in this way? But this is a very unusual situation where you can't set your price and your volume. Next year, the people who buy care from us are trying to reduce our prices and reduce the amount of cases that we can see because they can't afford to pay them. They'll pay us 100% for, say, 100 cases, and then for any you do after that, they wanted to pay 50% of the cost, which if you're an outlier on that fallow graph means we lose massive amounts of money on each of those cases. How can you do that when you've got to pay the bills? And after years of gradual efficiency, of doing the work with less nurses particularly, this Mid-Staffordshire happened, and there were 2 reviews which said, actually, to get really good care, you need lots of good nurses. And so the hospitals generally agreed to that, and there's been a big recruitment drive for nurses, and yes, we have more nurses, but we've got less money, so this is what we call a cost pressure. Nobody wants to reduce the number of nurses because you need them to get good results, although I'll come back to that in a minute. So now you have an additional cost pressure of more nurses to deliver the job, to get the quality right, because the public expectations are appropriately high, but we're having our budget squeezed. Less money, more demand, greater expectations, and rising costs. It's not a good setup. And John Appleby, in that report looking at what the NHS was being asked to do, had looked back at the productivity gains over time. Each blob represents the amount of increase in productivity you need to get year on year. And this is what we were expected to do from 2011 onwards. And his conclusion was, it's undoable. No corporation business anywhere in the world, in any sector, had ever achieved those productivity changes. So let's have another think about NHS finances as perceived by finance directors. 6 in 10 trusts, 60%, are now receiving financial support from the Department of Health directly. And if you ask finance directors whether they think things are going to be all right or not, then there's been a progressive reduction in their confidence that they're going to break even or even be in deficit. They don't think they're going to make the 20 billion savings that Nicholson asked for. And if you ask them about their confidence in the wider healthcare budget, they have progressively less confidence. In fact, they're actually very non-confident that it's viable. So let's call in someone who's used to turnaround and look at John Moulton of Better Capital. He does turnaround. He goes into businesses and sorts them out. He has one key business mantra. You've got to cut the costs to stop the cash drain. And so it is something that we currently now have to think about doing what we do in a completely different way. Which brings me back to Devi Shetty. And this is an article that appeared in the Wall Street Journal in 2009. Devi Shetty is the 8th of 9 children born in Mangalore in India. And he decided to do cardiac surgery after one of his teachers told him about the first transplant that Chris Barnard did in Cape Town. And he came to London after he graduated to work at Guy's. They did 6 years of cardiac surgery before being asked to go back to India to run a private hospital funded by a single family in India. He'd been there a year when he realized that the vast majority of people who were referred to him couldn't begin to afford the care that he was called upon and trained to deliver. And so he spoke to his father-in-law, who ran a construction company, and they built a hospital on a greenfield site on marshland, on 25 acres of marshland just outside Bangalore. He also operated during that time on Mother Teresa heart, and she influenced him enormously in trying to say you don't need money to do stuff. You need the skills, your native skills that you have, and you should be able to find a better way of doing this. And he keeps this statement on his wall. From 225 beds in Bangalore in 2000, they now have 7,500 across India, and with a plan to go up to 30,000 within 5 years. And I want you to remember what this looks like. We'll come back to it in a minute. Of course, what Shetty has done is absolutely obsessionally control costs. And the first is economies of scale. And as we go through these, I'll try and get you to think about whether we could do them here. He does 4,000 open heart operations in children in one hospital in a year. In England, we do 2,900 operations in 10 centres. You just have to think about what those cost differences might be in fixed overheads alone. And if you remember from my last talk, those of you who were here, we have singularly failed as a country to be able to merge centres into bigger and more economic units. And if you look at those 2 to 3 diagrams of the NHS that we saw before, do you wonder why? If you look at America, it's even worse. In Chicago, they do 750 operations in 9 centres for a hell of a cost. He has a different business model. Now remember, it's completely private in India. There is no state structure, so I'll come back to how it's funded in a minute. But the first thing is he does greenfield sites, no inner city building. Low construction cost buildings, prefabricated like the ones I saw you, single-story clusters of specialties around core facilities with a very low maintenance design. Does anybody remember the kind of hospitals that we used to have after the war with prefabs and long corridors? Yeah, he's back there doing something that is cheap, quick, friendly, easy, low cost. He also has a model which is Narayana elsewhere. In other words, he uses the assets of other organizations but puts his business model within it. So he'll own a ward or an area or a clinic, but delivered to their own way they do stuff. They do more each day and every day. Well, they must, of course, to deliver care at that volume. They have early starts, 6:30 starts, 6:30 for the operating room, and the patient is delivered to the operating room at that time. Late finishes, midnight, 7 days a week, with a shift system for clinicians. Now, the doctors aren't working much harder than they do in this country, but they're working a kind of rolling rota. You don't get paid more for working at weekends or the evenings. You just cover your 48 hours and you have a bit more time off in between. So it actually works 60 hours, so it's not like ours. And they work really, really hard. But it's a shift system when other people come on late in the afternoon so that you don't waste your assets in the evening. In this country, most operating is 5 days a week, a Judeo-Christian week. We waste our assets at nights and weekends. And an obsessional view about patient flow through the system. He has direct control of procurement. So he forces the suppliers down by using the reputation of Narayana to buy stuff. He buys locally if possible and refuses to accept the UK, US or EU prices. And he regards, for example, the CE mark and the FDA regulations as anti-globalization maneuvers, which I'm quite interested to see. He standardizes techniques, so all the surgeons have to do it the same way. All of his 50 surgeons have to do it the same way and use the same equipment and the same sutures. That makes it much cheaper to start with. And he challenges the single-use concept. For example, when we get a patch to cut up and put in the heart, we only cut a little corner out of it, and we throw the rest of the way because the manufacturer makes it quite large. But in India, they re-sterilize it. And we used to do that. But after BSE and a bunch of other things, that's now not allowed. But the evidence in India is that is not necessary. You can sterilize them and use them well. So you have to balance cost and risk, and he has to do that every day. He engages the staff very directly by giving them profit and loss data for the business, for their area, and for their own performance every day at 12 o'clock to their mobile phone. And he trades on their competitive instinct. If you get doctors and nurses in one room, they all want to be better than everybody else. And if one of the criteria you're judged on is keeping your costs down, you don't have to do any management. He calls it doing 1,000 small things. And I'm very moved by this Mazda advertisement. Some of you may have seen. This worker decided to take 1 gram off every component to meet the corporate need to take 100 kilograms off the weight of the car, instead of buying a smaller wheel or a smaller engine. 1 gram off every component. 1,000 small things. And it worked. So the parallel is, could we not harness the power of everybody in the organization just to save £1 every day? That's how he works on his profit and loss ratio. For technology, they use social media instead of the post, instead of email. They use WhatsApp as their preferred medium of communication between doctor and patient. And they use audio and video rather than text, because that and the instant messaging they found empowers the patient, massively reduces their administration overheads, and is excellent for them because 60% of their patients are illiterate. They can recognize the WhatsApp icon, and then they're sending all their data by text, verbally, or by phone. Now, it's a brilliant idea, but we can't do it in this country for very obvious. By the way, they use it for patient feedback too, but for quite good arguments about information governance. Information governance says no, because WhatsApp leaks information in a way like Facebook and all the other things. It lives on the cloud, but his community of patients accepts that risk because they get better care, better communication, and there is no delay in transferring your prescription to your pharmacist, for example. And actually, a large number of people who study this field, here's a note from the Foreign Affairs magazine looking at studying the intelligence community, that the bits of data we leak out anyway every time we use a computer are actually making the concept of privacy an archaism, and that it's doomed regulation to protect personally identifiable information. I'm sure there are many people in this audience who would challenge that. And we need, at the moment, to keep health data completely confidential for reasons which you'll all understand. But this is a problem which we should be able to work out. The experience of India is that using the post and using a number of other communication methods is a total waste of time and doesn't engage the patients. We need to find a secure way of doing this to make it more efficient. So could we do any of this here? Well, we've usually asked for more rather than for less. I'm working out, that's just a tradition. We put in a business case to get more staff. This is a new way of thinking that we have to adopt if we're going to survive in this. But if we compare India on the left with a large population, no universal access, people having to pay, a more spiritual system where they're grateful for the treatment and that they must travel, compared with what we have on the right, where our population needs are met, everybody gets it for free, patients don't like to travel, as I explained last time. Shetty has set up a kind of insurance system called micro-insurance, where they pay a tiny amount of money and each patient pays what they think they can afford. And it turns out that people are generous and they pay roughly the right amount. And over the course of a year, the rich people pay more and the poor people don't pay anything. And it averages out to cover his costs. People are altruistically motivated to deliver it. Their case mix is a bit simpler, and there's no problem with doing it in a single centre. It's a free market, and it's centralised itself. They only have these 2-star accommodation and not much choice, whereas we have complex case mix. We still need, some of these patients only need, 88% of our patients only need to come to our centres once. They can have the rest of the care locally. But people like 4- and 5-star accommodation, and they like to make choices. I wanted to go back, before I finish, to look at the procurement. This is a very good website on the bottom, which is in the manual. But you can work on this website to look at the cost of procurement for various items. So I just picked one at random, which was vinyl gloves, large, pounds per 100. Across the NHS, these are the different prices being paid for at the NHS for just a box of gloves. It's twice as the red ones there are paying twice what the ones at the bottom are. If he can leverage down the costs of products, why the hell can't the NHS? We are being milked by a bunch of private sector companies for which we could do an awful lot better, I suspect. The research that's done into staffing ratios is very poor and a little bit outdated. I'm not saying that we should reduce the number of nurses we have by the bedside, but I think we need to understand whether nurses are the right people to be doing certain jobs. 30% of nurse time in an intensive care unit is spent making up drugs. In Seattle, those drugs are made up by a robot in the pharmacy, delivered by a robot, and checked by barcode by the bedside. That means you could save 30% of your nurse salaries, or probably nearer 20, and since we're nearly always 20% short of the number of nurses we need, we might actually be able to employ the right number of people to do the jobs that we want them to do if we worked in different ways. Bruce Keogh is trying to introduce 7-day working, but the BMA and the nursing, and BMA particularly, is fighting this because it wants to pay doctors more at weekends and in the evenings, and says that they won't want to work 7 days a week. Well, we go to the restaurant, we go to the theatre, we go shopping at the weekends, and I think if you change the rotas around in a more sophisticated way, society could live with that. We currently start our operating list at 8:30 in the morning. As I said, Devi Shetty start at 6:30. He expects the anaesthetist to be there with the patient on the table at 6:30. In England, most anaesthetists send for the patient when they arrive. So the patient here is delivered at 6:30 and the anaesthetist performance is judged by whether they turn up or not, which means that the next patient is there on time and so on. There are many little things that you could do to improve the way we work. By focusing on the patients and designing the care around them, identifying value for them and getting rid of everything else that we pad our day with, getting it right first time because complications are expensive, and getting rid of eliminating waste. Any of you who've done any kind of management at all will recognize that as lean or Six Sigma. It's the same. There's no reason why you couldn't apply it in healthcare. It has been successfully in Virginia Mason in Seattle. That requires standardization and standard operating procedures which are alien to British doctors. They're very alien. And we need, I think the experience of the profit and loss data is really telling. You need the right information at the right time to the right people in order to influence their behavior. If you give them no data, they won't change. And we maybe should consider devolving tasks to lower people. I was challenged by one of my management coaches to say why I was still closing holes in the heart. And it's a straightforward operation. It's something I do quite well through a small scale and the patients get better. And he said, well, you're nearly the most expensive doctor in the hospital and you've just told me it's an easy operation. Why are you doing it? It's a good question. But most of the public would always try and find the best surgeon for the job. So you're forcing up the cost by choice unless you can demonstrate that the devolved person, is as good or better than you. So maybe we should be judged by the quality of our trainees and not by our own performance. I've been privileged to work with these two guys. Eugene Litvak is a mathematician at the Institute of Healthcare Optimization in Boston, and Peter Willits, who is an expert in lean management, who now works for APT Global and was formerly with McKinsey. We had them working in the cardiac unit, giving us a lot of advice about how to get more patients through for lower cost. And we did it. It was brilliant while they were there. They had skills that we didn't have, and they knew how obsessionally to look at all the stuff that makes a patient flow well and efficiently and cheaply. And we could not sustain it because none of the staff I work with are trained in these methods. And if we really have to respond to the government's agenda for cost-cutting, we've got to think again about how we do it. And not just us. This is somebody looking at the American system a couple of years ago. And I think that is quite a good quote. We do need systematic cost control. If you were running any kind of business, that would be wrong to waste the money of the company or, in our case, the public money. We need to use it wisely. But that requires strong political decisions, strong social decisions, and an understanding of what the public is willing to pay for. This is the results of tetralogy repair in England. Survival between 2006 and 2009, 100% survival for that operation, essentially, in the UK. Fantastic results. This is Great Ormond Street out here, doing the most. But I don't know a couple of things about this. I know we've all got a good survival, but how much did it cost? And how much do we add value to the patients who've had that treatment? So if we do it for 10 times the cost of this centre, and we're doing more cases, then we've wasted a lot of public money. If the other way around, we're doing it for 1/10 of the cost of this centre, then we probably ought to get more patients referred to us because we're very efficient, or export our methods. We need to add value to our results data. And what do you value? You're going to have to make these choices. So do you value having this service locally? Do you value having perfect facilities like we have at Great Ormond Street, lovely big rooms, nice windows, your own loo in the private room, an excellent intensive care unit which is relatively quiet, nice big elevator? Or would you rather have it done for a tenth of the price in a prefab just outside London? Or maybe somewhere even cheaper, where we could organise the travel effectively, but the results would be just as good. And then maybe afford to invest a bit more in schools. We can do it for less. Devi Shetty's shown that. But will either you as the public or the government who are giving us the money allow us to do that? My worry is that because this squeeze on our finances is so acute and so strong, and there is not an alternative supplier likely to appear in the next 5 years, that some of these big organisations which are theoretically delivering great care will go to the buffers before we're ready with an alternative supplier. This is Polly Toynbee, who writes in The Guardian, and this is a quote from her which I think is very telling. I'm obsessed by health outcomes, as certainly some of you in the audience know. I really want to know the results of what we do, and I want to benchmark those worldwide. But Polly Toynbee came up with this, which I think is something rather telling. You have a very important opportunity in 2015. No one knows what's going to be in the final manifestos. But in the last election, the big thing was not in a manifesto. The thing that changed our lives most in the healthcare wasn't there. Austerity was, but I don't think we'd anticipated how difficult it would be to manage, or that coming into this election, it's all going to get worse. So as you make your choices, look carefully at what all of the various parties want to do and consider what you want your health service to look like and whether you want to have the very best healthcare system in the world, which I'm very glad to say I feel part of, because the evidence was there in 2010 that that's exactly what we were. This is an opportunity, this health service, to deliver some of the best research, some of the best outcomes, and some of the happiest patients, if only we can keep it going. Thank you very much.